Okay, before I go on to the idea of what is evidence-based medicine, I just want you to understand what medicine as a science is in comparison to, say, a physical science, physics for that matter. Okay, and there is a very big difference, because medicine as an idea is rooted in empiricism, in contrast to the rationalism that you would see in, say, physics, for instance. And what you mean by empiricism is very clearly, it is knowledge that is based on experience, or rather by the use of our senses. Okay, what we see is what we believe. Ultimately, you see a change, you believe it, and then you formulate some kind of a theory behind how it works. Okay, and a lot of what we do in medicine is based on that experience. It's very important that as a consequence, the primary way in which we investigate anything in medicine is through an experimental design of some kind. And we have to recognize that when we do get results under these circumstances, it is never a certainty. It is almost always looked at in terms of a probabilistic kind of an endpoint. This is completely the opposite of what you see in say, physics for that matter, where it is based on reason and logic, not necessarily on what you see. In fact, it is always considered that experience is usually a low quality kind of evidence, that you don't build your theories based on that. If you talk to any mathematician, he'll tell you about the beauty of his theory. You know, what is beauty, what is perceived is very, very difficult. It's completely different. So considering that medicine is an empirical science, to argue that we are going to talk about evidence-based is nonsense, because all of medicine is based on evidence. We do need to have our senses, we need to look at what goes on, and observation is a very essential part of what we have to have in medicine. So to say evidence-based medicine, is it good or bad, is a bunch of nonsense. All of medicine is evidence-based, but what we are defining here is what a group of people, dominantly epidemiologists, have appropriated and used as what they call as evidence-based medicine. And what is that evidence-based medicine? That evidence, as they say, is something that is on top of a hierarchy that they have developed. And this hierarchy, which is topped off by randomized controlled trials and meta-analysis of randomized controlled trials, is based on two issues. That is, as the size gets larger, the precision improves, and as the size gets larger, it is alleged to be more accurate in terms of its representation. Now, in addition, the quality of the studies also seem to go up, and a randomized controlled trial would be considered as the best of quality. So what we say when we say evidence-based medicine is basically the information that we get from large randomized controlled trials. And I think that is what I need to critique. Are these large randomized controlled trials the valid way to look at it? Now we need to go back and say, where did these ideas come to us from? Why do we focus on randomized controlled trials and on large trials? And that idea comes from the champions of all of that, which is this original paper in 1982 by Sachs, Chalmers, and Smith, which basically said that if you look at multiple therapies and look at it in terms of observational studies, the differences that you see with these therapies are much more prominent in observational studies than they are in randomized controlled trials. If you do a randomized controlled trial, what you thought was a difference disappears. So they went around with the belief that what you see in randomized controlled trials is real, and what you see in observational trials is probably some kind of an exaggeration. So with that, the RCT has been given a lot of preeminence. Additionally, being epidemiologists, they have a very strong investment in the methodology, and basically they feel that the precision of our estimation of these differences between treatments is going to be based on size. This is based on a very simple statistical principle that when you're looking for differences in small differences in size, when you take small samples, the estimate of those differences are going to be extremely wide. What you call your confidence limits are going to be very wide. And the only way in which you can demonstrate these small differences is by increasing your numbers. And you narrow down your confidence intervals enough to show a difference between these two specific treatments. And this is the idea behind today's evidence-based medicine. randomized controlled trials, and not just randomized controlled trials, but large randomized controlled trials should be the source of our knowledge. And I'm going to debate whether that should be the source of our knowledge. Okay, debate just myself, not with Dhruv or anybody else. Okay. Okay, understanding randomized controlled trials, most of us have a little bit of a problem. So what I'm going to do is I'm going to try and see if I can just look at it in a simplistic way. If I ask a specific question, does a treatment, say A, improve an outcome X in comparison with a control which is untreated, okay, either with a placebo or is treated with routine kind of therapy, we need to see what is the difference. To do this, we need to recognize that we need to change A alone between these groups of patients and nothing else, okay? And we have to make sure that this change, okay, should be in a way that no other treatment is modified because of these treatments alone. Or in another way, you should be sure that all other treatments are equivalent, and that in that sense, the patient should be blinded to the allocation and the treater should be blinded to the allocation so that they don't change the way in which they react to a given patient. Additionally, we look at an outcome X under these circumstances, and we have to recognize that this outcome X is not only affected by the treatment A, but by a whole range of what are called confounders. So the only way in which you can minimize the existence of these confounders is to make sure that between the treatment groups an equal mix of confounders occurs, and as a consequence, the only way we can do that is by randomizing these patients and probably even selecting these patients so that we get a relatively homogeneous group of patients to be treated. And the third aspect is to choose controls that are concurrent. We know that historical controls have no real relevance because they are handled in so many different ways, that ultimately these patients should be also blinded to therapy so that we don't influence other management issues in these controls. And this is the broad idea behind a randomized controlled trial. And we focus on these three aspects when we do a randomized controlled trial, which is number one, we attempt to select patients to get a homogeneous group. We randomize them to allocations so that there is a balance of all risks on these patients, and we blind the therapy to guarantee that equal treatment is given to both these groups, and that is the idea behind your double-blinded randomized kind of trial. Okay, let's look at a typical randomized controlled trial under these circumstances. It's very typical that to get a randomized controlled trial, a very large number of patients with a primary disease are usually screened. And then we set very tight features which are either inclusion and exclusion criteria, which narrow the patients down further. And then ultimately we require that they have to give you some kind of a written consent which narrows it even further. That ultimately it is not unusual that about 10 to 15% of the patients who are eligible for the trial are ultimately subjected to the trial. This creates a concern in the sense that it is a small group of a very large group and may not necessarily be truly representative of what is going on overall. And there is a reasonable amount of data to show you that when you look at outcomes, say for instance in patients who are excluded from randomized controlled trials, it is not the same as the control arm. They seem to be very clearly having different levels of mortality. Here is data from the GRACE CAD registry, which were patients who are subjected to, were recruited for randomized controlled trials and then taken out effectively as non-eligible kind of patients. And you look at the non-eligible patients, they have differences in mortality. So it raises a very strong concern whether this process of selection is basically taking out a very atypical group out of this whole set of people with diseases. This aside, additionally, when we perform randomized controlled trials, there are randomized controlled trials with an intention to show the efficacy of a specific treatment or what we would call the effectiveness of the treatment in a general population, and we design these trials in slightly different ways. An efficacy trial is one in which we are trying to say, if I provide treatment X, okay, will it improve a specific outcome wise? So we're trying to find if there is an efficacy of the treatment in a given situation. And for that, we should recognize for us to show an efficacy, we probably need to have a very homogeneous kind of group of people. And very typically, to do that, we narrow the case mix dramatically. We narrow it down to a very narrow subset of the overall population. A good example of this to me would be this out-of-hospital witnessed cardiac arrest when you used hypothermia. The initial trials on hypothermia are dramatic. The number needed to treat is roughly about 6 or 7 patients to have one good neurological outcome at the end of 1 year. That's a very good kind of an outcome. The only problem with that is the selection was very narrow. It is not everybody with a cardiac arrest. It's not everybody with a ventricular fibrillation arrest. It was everybody with a witnessed ventricular fibrillation arrest out of hospital, okay, who were included in that trial. And when you really look at that, it is a very narrow, homogeneous group in which this therapy worked. But the problem will be to say, tomorrow if I want to apply it to patients with all cardiac arrests, I can't extrapolate. I can't even extrapolate it to all ventricular fibrillation arrests for that matter, primarily because it has narrowed it down. So an efficacy trial has very clear limitations. Number one, besides the fact that it is restrictive and is difficult to extrapolate, it usually ends up to be much more expensive. You need to recruit a large number, eliminate a lot, and take just a few. And because it is smaller, the evidence-based hierarchy won't like it because it's a smaller size trial. The estimate of your confidence intervals are going to be larger, and they will say it's a low quality study. So what do we do in tradition? If you saw the last 100 papers in critical care, probably 90 of them were not efficacy trials, but what we would consider as pragmatic trials. These are trials of what we call as effectiveness of a therapy in the general population that you're dealing with. And the classic example of that is this saline and albumin study. What do we all think about the saline and albumin study, the so-called, SAFE study, right? We all think that it clearly proved that albumin will not harm a patient. Okay, and I would raise a strong concern. Really what they did in this was, they needed to randomize 7,000 patients so that they get that big number in the first place. And when they did that, how did they pick the patients? If you went to that ICU, they'll press your finger. If you had underperfusion, you're randomized into a treatment group. The selection criteria are extremely wide. And as a consequence of that, if you really look at this, basically the number of patients with single organ failure, okay, with no organ failure, 50%. So the ones with 2 or 3 organ failures is a significant minority, less than a quarter of this entire group. 1% required renal replacement therapy, about 2% had ARDS. Is that sick by any definition? No. The length of their stay, they say 6.5 days plus or minus 6.5 days. When you have a standard deviation equal to the length of stay, that means you have a confidence interval that is wide, which means most of the patients were 1 day in the hospital. They were 1 day on the hospital, 1 day on a ventilator, didn't have ARDS, didn't have renal replacement therapy, and they got how much albumin? They on average were told they got 1 liter of albumin plus or minus 970 ml. So if I was to draw my confidence interval, there were some people who got negative albumin. The albumin is sucked out of them. Since that is not possible, what do we have? We have a deviation like this, that the majority got probably about 200 ml of albumin on a given day. You're checking toxicity of a drug in a critically ill population that is not critically ill. You're giving a very small volume. And as a consequence of this, the SAFE study only shows you what? The average effects of albumin on 7,000 heterogeneous ICU patients who were not sick on average and who were given small volumes of albumin. To say that this will show the existence or absence of toxicity is a bunch of baloney. So effectively, if you notice, this is very extrapolatable. Now I can run it to every other unit and say I will find that albumin doesn't hurt most of our patients. That's very true. But where it does hurt is when you give large volumes in very sick patients, and we don't have evidence from this. So the problem that we face with randomized controlled trials is they're all not uniform. We have efficacy trials that are not externally valid. They are not extrapolatable like the hypothermia studies. And we have pragmatic trials which are not even internally valid. They have no substance in terms of establishing or disproving any specific issue. So this is a problem with randomized controlled trials. We don't have any way in which you can use it for getting genuinely useful information. The other problem with this entire idea of evidence-based medicine is the preoccupation with size. Okay, the belief is, and it is true, that the larger the study, the precision improves, and therefore you will be able to estimate your median values extremely well. But when you use a large study, you have to dilute the science behind the study. Okay, it's very difficult for you to do titration of individual therapies randomized to 2 different arms. Okay, on the other hand, you can do protocolized management on one arm versus another. And as a consequence, the large trials, okay, which are not only expensive because they need to recruit a large number of patients, they narrow down or clearly narrow down their selection criteria, making it non-extrapolatable, and at the same time, the design issues are something that you need to worry about, primarily because they don't deal with the science in any way. They deal with precision, not science. Another thing, I just want you to look at this, and all of you might be familiar with this, that is the ARDS net high PEEP versus low PEEP strategy studies, which clearly showed that when you apply high amounts of PEEP in contrast to low amounts of PEEP, there was no difference in terms of survival, and everybody went around and said, oh look, it doesn't matter, we just use the low PEEP strategy. Now the problem with this is, when you are doing this and randomizing patients, you have a range of patients between recruitable lungs and non-recruitable lungs, and some of them respond to PEEP and some of them don't respond to PEEP. So if I used a strategy of using high PEEP, there will be some responders, some non-responders, and on average, this outcome will not be very different. On average, there may be value for the responders, there may be no value for the non-responders, but when you take a heterogeneous group and apply it, it is going to be a problem. So my concern is also randomized controlled trials focus a little too much on the average. And that average is what I really worry about, because these averages are non-informative. So if I may say, as a population, you will not respond. Does it mean that there will not be a subset of you that will respond? Randomized controlled trials have no way of easily identifying which subset will respond and which will not. Okay? And I feel that the best way in which I can illustrate this is through this cartoon, what I call the flaw of averages. You can say that this lake is only 3 feet deep on average, but you can sink and kill yourself because there is a point that is a little deeper. There is a serious problem that randomized controlled trials deal with measures of central tendency and not with the variability that really exists. In addition, this entire idea of evidence-based medicine has a very significant derision, a hatred for anything that is non-randomized control. Okay, and it's based on that old idea by Chalmers and Sachs, where he showed that these trials with observational studies don't show you, a significant difference, while RCTs don't. But we have to understand that from that lesson, we have learned a lot. We have done a lot to improve the quality of observational studies, that today, if you really look at it, as you see, this is again about a decade ago. We had enough evidence to show that the prediction of outcomes from good quality observational studies is exactly identical to what you derive from randomized controlled trials. So it doesn't really add dramatically to the whole process. So randomized controlled trials have a whole bunch of problems. But I would ask you to go back and look at this idea that Sachs and Chalmers basically had. They clearly said, on the basis of their studies, okay, that randomized controlled trials are more accurate and observational studies give you an exaggerated difference. Why can't it be the opposite? Why can't it be that randomized controlled trials are far too conservative? Okay, they are far too conservative, and what we need to see is probably what we get from other observations. And this is something that I really worry about. And basically, it's very ironic that the entire edifice of evidence-based medicine is built not on a randomized controlled trial, but an observation of multiple randomized controlled trials. So it does admit to the fact that observational medicine has a role. Okay, and that is something that we should again really look at. Okay, now the idea behind randomized controlled trials is what we call this OXO paradigm. As an observational science, we can't predict how outcomes will occur, but what we do is we throw something at you and see how you respond, the OXO. That is, we have a process of observing the patient, treating or perturbing the patient X, and then observing again. Okay? And the randomized controlled trial, no doubt, is the best example of this OXO paradigm. But is this the right paradigm? And I would ask you to look at it in the context of this. Parachutes to use to prevent death and major trauma related to a gravitational challenge. Systematic review of randomized controlled trials. As you expect, this was in the joke edition of the BMJ, all right? And very effectively, the results, we were unable to identify any randomized controlled trials of parachute intervention. So do you reject the fact that parachutes are life-saving? No, because the way in which we need to look at it is not through the OXO paradigm, which is effectively trying to say whether a specific treatment works, but to look at it very differently and say, how does this treatment work? How does a parachute work? We know how it works. It reduces the air resistance and slows you down. And when does it work? Not when you jump off one stair, but when you jump off a plane in a reasonable height. Okay? And this is a very different paradigm. We are looking at the mechanism and the context in which it is working, an entirely different idea known as the CMO paradigm. And we need to look at everything in this way. We just don't look at it in terms of just how it changes, but in terms of whether there is an honest mechanism that can work under specific circumstances, and that is basically the way we need to look at it. Just to go back to that, the old parachute recommendation, there was a tongue-in-cheek recommendation over here that advocates of evidence-based medicine have criticized the adoption of interventions evaluated by only using observational data. We therefore think that everyone might benefit if the most radical protagonists of evidence-based medicine organized and participated in a double-blind, randomized, placebo-controlled crossover trial of the use of the parachute. That's a good way to get rid of people who talk too much about evidence-based medicine. Ask them to jump off the building without a parachute, or at least assign them randomly to one or the other. Okay, are there alternatives to the use of the RCT? I argue again that the prospective observational cohorts of the modern day are very reasonable. We have the so-called CRICO and SOAP cohorts, which are very, very, very instructive as far as we are concerned. There are probabilistic methods which allow the inclusion of non-randomized controlled data, Bayesian analysis for meta-analysis, for instance. And there are Monte Carlo simulations, which I talked about in my previous talk and consistently was ignored by the rest of you. But there are ways in which you can do it. But I'm particularly thrilled by this very recent paper that came out. You remember your driving pressure paper, which was a very innovative way of looking at the data again. This was high quality data that was accumulated in randomized controlled trials, but it was analyzed in a very innovative way to give you a sense of understanding of what really goes on. We don't need an RCT to get the ideas of driving pressure in any way. We probably will never get it in one of those trials. So very, very clearly, what can we conclude? The current paradigm of EBM that is based on RCTs is clearly inadequate, since it emphasizes RCTs over other things and size seems to dominate. Context-specific studies, like we see in the recent past, are probably far more relevant. My suggestion to most of you is, whenever you read all these randomized controlled trials, we need to have some way in which we develop an art of skepticism. Anybody who's seen this very famous cartoon with Charlie Brown, every time coming to kick the ball and it gets yanked out, he keeps doing it again and again and again. Okay, how many more randomized control trial and negative randomized control trials do we need to go through to lose our faith in evidence-based medicine? I think we need to seriously look about ways in which you look at it differently. I was recently shocked by this particular paper, which told me that everything I knew about the management of ARDS was wrong. It's another randomized control trial, and my reaction is going to be just that. Thank you.
Thank you very much.